for having me on this webinar, and greetings to all my senior colleagues on the call. Dr. Lebuti Odison and I have been on a couple of programs together for the NMA and Medical Guild. So Dr. Shuni, a mentor that we all look up to, and same with Dr. Ogumbi. So my special regards to you all. Said, I'd like to start from the point of view of the primary care system in Nigeria, and I will be using Lagos as a reference point. In Nigeria, the PHC system, the primary care system, is the grassroots healthcare sector. That is a healthcare sector that caters for the ordinary man in the community, the grassroots population in the community. So it's the first point of call for the people in various communities. And whatever we want to do, we'll start from there. The PSC system is expected to cater for immunization activities, treatment of minor ailments, family planning, vaccine, and what have you. But the problems we have in Nigeria can be categorized under the 6 building blocks of the health system, which will include the leadership and governance, problem with healthcare financing, service delivery, workforce, and then we'll be talking about things like infrastructure and service delivery as well. So if you start looking at this from the point of view of leadership and governance, you would see that it's the same problem that we have in Nigeria. A lot of people in charge of the PSC system are not true to the system. They're not doing what they ought to be doing. They probably, some of them are probably not the right peg in the right hole to provide the required leadership that we should have in that kind of sector. And I'm not talking about the national level. I'm talking about at the local government level or at the state level. If you take Lagos, for instance, Lagos is doing very well in terms of the PSC system, the organization, service delivery, and what have you, because they have a lot of firsts that we can mention, that we can, credit to their name. But in other parts of the country, especially in the Northwest and the Northeast, it's a sore case because the problems, the challenges tend to rise from the fact that we do not have medical practitioners or public health physicians being in charge of the PHC system in this part of the country. Apart from that, we have a dearth of infrastructure. Infrastructural development. It's a major eyesore in the PHC system. And if you are conversant with the social media space, you would see a lot of dilapidated buildings, a lot of buildings that are situated in hard-to-reach environments, a lot of buildings without power, without water, without good roads to create access to community members who may wish to visit these healthcare centers. So we have several of these in different parts of the country, and even in Lagos here, we have some PSCs that are not functional. So we have infrastructural debt in our PSC system in Nigeria. And of course, we all know that image is everything. I mean, somebody wants to bring his wife to, register for ANC at a PHC center or to deliver at a PHC center, and you look around in the environment, you look around the structure, and you're like, oh no, my wife cannot deliver here because you have moth-eaten roof, or the roofs are off, or there's no water, or there's no fence, there's grasses everywhere, there's no power in the center itself. So how do you even expect the workers, the healthcare workers in that kind of structure to be able to deliver their services very well? Then apart from that, you have a dearth of consumables and commodities. I remember back in the days when we were in training, once you just go to the GOPD or the emergency room, all you need to do is just look at the nurses station and all the consumables that you probably need to attend to patients are there for the taking. And we used to stock some of them in our ward codes at, as house officers. And, cannulas, cotton wool, plasters, all those items we used to stuff in our ward code so that it makes the work easier for us. It makes the work faster for us. The response faster, as the case may be. But nowadays, you visit some of these PHCs, you can't find any of these, maybe because there's not enough money to purchase, or because money has been voted, somebody has, decided to use the money for something else. So you don't find adequate commodities, adequate consumables. You don't find enough equipment. There is a report by the NPACDA. NPACDA is the National Primary Healthcare Development Agency, which is the organization that is in charge of PSCs and PSC services in the country. And they reported that less than 25% of the PSCs in the country actually have up to 20% of the equipment, minimal equipment required to run a PHC system in the country. So you can imagine if you don't have up to 1/5 of facilities that have the right tools and equipment and machines that they need to attend to patients. You can imagine that such centers cannot, judiciously attend to patients. They cannot judiciously contribute a positive indicator to the healthcare outcome in the country. So PHCs do not have sufficient commodities, they do not have sufficient consumables, they do not have sufficient equipment to run their centers. Apart from that, the finances to purchase drugs, to stock drugs, to pool vaccines to the PHC, to pay the workers, to paint, give some form of aesthetics nature to the PHC is also lacking. To address this, the federal government actually inaugurated what they call the Basic Healthcare Provision Fund, the BHCPF, in 2014, and I think it came into operations in 2015, thereabout. So this fund is supposed to be derived from the Consolidated Revenue Fund, 1% of it, to assist the PHCs, to give some form of financing to the PHCs. But in the past couple of years, the finances have been dwindling. They've not been stable. Yeah, of course, the fund itself is even very much inadequate. But of course, if it is delivered when it should be delivered, it will at least bring some of succor to the PHC system. But the funds have been dwindling, maybe due to political will or budgetary allocations and what have you. So we have these problems, beleaguering the PHC system. Then we have the workforce, which is almost inadequately trained. Like I said, if I start using Lagos as a reference, Lagos has almost near adequate workforce in the PHC system because they are the first to start inserting doctors, medical practitioners in their PHC running 24-hour service in the country. If you travel up north and some other part of the country, you will find that the only cadre of healthcare workers that you would find in the PHC system are probably maybe a nurse or a community health extension worker, which is inadequate, grossly inadequate to run a PHC where people are expected to come for family planning, come for treatment of malaria, come for immunization, come for TB diagnosis, come for all sorts of other activities that go on in the PHC system. So, and when you have this workforce, they should be, naturally be undergoing training and repeated trainings and on-the-job monitoring. But this is lacking, of course, partly due to lack of political will, or largely due to poor financing of the PHC.
So we have Yeah, and I'm sorry to interject to there. I want you to hold your thoughts there because again, you've really, approached this from a different angle that personally I didn't even see coming, right? I knew we were going to talk about the healthcare sector and also, the public and private sector, but it was really, really important to actually have you emphasize the PHCs because you're absolutely right. I mean, the PHCs are the foundation of any economy. So I would want you to please hold your thoughts there. You're already providing some of the solutions, even though you're identifying the challenges, which of course our audience here are listening on. But I would want to just, go over now to Dr.
The opportunities, I think, there are quite a number of opportunities in the healthcare sector in Nigeria. Obviously, we're talking about Nigeria, but for me, it's mostly about Lagos because Lagos is where the hospital is based. And that is the opportunity, seeing the opportunity to provide excellent standards of healthcare for Nigerians in Nigeria. Now having Marcel Ruth will be operational 4 years in December. And I think for me, I was not in Nigeria for quite a long time. So maybe missed the period where there was a lot of patients just basically leaving the country to go abroad for all their care. What we're trying to do now, we're managing to do, I think, is to provide the type of healthcare that patients would receive if they went abroad. So a bit of a reverse medical tourism, I think, is probably what you would be saying. We're being able to provide, certainly in the private sector. So we've been operational just about 4 years. We've seen almost 4,000 patients in Marcel Ruth. We see patients coming from all over the country. We're now seeing patients coming from neighboring West African countries, including Liberia in particular. In fact, the ambassador came to see us because he couldn't understand, what we were providing that would allow the increase in visa applications, for example, for people wanting to come into Nigeria to come and seek medical care. Patients from Cameroon, a few from Ghana. We're now seeing patients coming back from the UK and in the US, and in particular, when patients go for their maybe wellness check or for some other reason, some are visiting relatives, they get a diagnosis made, and if they don't have insurance, then medical care abroad is extremely expensive, particularly in the oncology sector. And what we're finding now is these patients are coming back, and they're actually coming back because particularly in the UK, there are doctors in the UK who are now telling them that they're aware that we exist and saying to them, look, it's better for you to go back and have your treatment at home, nearer your relatives and so on, but also so that you don't run out of money here and run into problems. So I think for me, that's been a huge thing to have that sort of impact, and particularly delivering care for cancer patients. When, the time when they've been diagnosed, it's not the time for them to now be getting on a plane to go to India, South Africa, the UK. And cancer treatment takes quite a long time to deliver. The majority of our patients are being treated for 9 months, sometimes a year, because they require chemotherapy, surgery, and radiotherapy altogether. So if they went abroad, they'll be away from their home, their family, their friends. Most of them will have to stop working at a time when they need the money to pay for their care. So for us to be able to deliver this care in Lagos for Nigerian patients has made a huge difference in terms of them being able to be at home. The other, I think, for me, the positive things, and because in my career, I did a lot to do with teaching and training. I was postgraduate tutor at the London Deanery. I also did quite a bit of research, and what we've been able to set up at Marcel Ruth is actually an active teaching program. And in fact, in the last few weeks, we've just been accredited by the National Postgraduate Medical College to run a residency program for oncology, for clinical and radiation oncology. We'll be the first private hospital to be giving this opportunity. So again, fingers crossed, we'll not just be reversing medical tourism, we'll be reversing the workforce feeling that they have to leave the country to go and train abroad. So that's another thing. And it's just so much, really, I think, in terms of being able to improve healthcare. I think the challenges we can talk about obviously the challenges in running any type of business in Nigeria. At the moment, of course, we have major issues with electricity and so on, which I'm sure
Right.
and the cost of treatment, I think, for the general population remains a big one. But I think there are other people on this panel who are more experienced in trying to discuss the financing of healthcare. But from my point of view, because people always ask me this question, and I can, from the bottom of my heart, say that I think it's probably one of the very best things I've ever done in my life. I'm really grateful to God for this opportunity to be back in Lagos, to be working alongside colleagues who I trained with or not, both in the public sector. I do a lot of work with the associations, the guilds, the medical women's, and so on. And it's huge seeing the amount of work people are trying to do in the public sector with hardly anything to do it with. And so
Right.
it really should be applauded for it. But like I said, for me, it's been incredible to be back at home and to actually day to day be able to try and improve not just healthcare for patients, but to be able to teach and train. And we're also doing quite a lot in the research and development area, which I think maybe I'll leave for a little bit later on.
Good.
Thank you.
Right. Yeah. Thank you, Doctor. And it was important to actually let you exhaust your thoughts in that, because again, you know, sometimes we see doctors and we just think one way. We just consider we're boxing them up into that, you know, that white coat as well as the lights in the room. But as an entrepreneur that you are, because that's really what you are as well. That's why it was important for us to allow you to really exhaust that thought process and really share light from a diaspora point of view, as well as an on-ground, you know, citizen right now who's actually giving back to the community.